Hi and welcome to another video tutorial by Synapse. Today we shall be taking up an extremely important topic from gynecology, that is carcinoma cervix. Okay, let's discuss about carcinoma cervix. Okay, so now before we talk about the carcinoma part, let's just understand the normal cervix. Okay, here we are seeing. Okay, so this is how you're going to see the cervix when you do a per speculum examination. So this is the cervix of a nulliparous woman. Okay, it's very easy to understand because look at the os, it is very uniform and tiny. Okay, so if I draw the same thing here again, I do the same. Okay, let's do that here. Okay, so if this is a cervix, which you're going to see on per speculum examination, okay, you're going to see structure like this and structure like that. Okay, so this tiny thing is the external os. Okay, so this is the ectocervix and this part is the endocervix. Okay, and then this line, okay, which is dividing, basically demarcation between your ecto and the endocervix, is called as transformation zone. So let's get this thing clear. Okay, now you're seeing the cervix here in cross section. See, this is the uterus above, correct? So this is the continuation of the uterus part. So this is the intrauterine part of the cervix, and this here is going to become your vagina, correct? So this part is the vagina here. Okay, so this is the vaginal part and this is the intrauterine part. Okay, there are two parts of the cervix. Fine. So now here, what you see, this is the ectocervix, which has been labeled here, right? The exocervix or the ectocervix. Now this part here, so this glands and all this and all forms the endocervix, the internal part. Okay, this is the endocervix. And the external os is the opening of this vaginal part of the cervix. Okay, this is the external os. Now, logically, if you see, vagina is lined by the squamous epithelium. So, what will be the ectocervix lined by? It will be lined by squamous epithelium. Simple. Here there is squamous epithelium. And then endocervix here, it is having glands. It is continuation of the endometrium, so which is again full of glands. So it is columnar epithelium. Here it is going to be columnar epithelium. Now, look at this transformation zone. So what is happening here is the squamous epithelium is getting converted into a columnar epithelium, or the actual way is the columnar epithelium, as it comes outside, it is getting converted into squamous epithelium. So that is known as the transformation zone. Okay, okay, fine. So now when this is clear, let's move ahead and let's talk about this in detail. So now we have to understand the transformation zone. Okay, because the whole carcinoma cervix revolves around this one concept. Okay, if this is understood, CS cervix will be clear. Okay, now this transformation zone, is it constant? Absolutely not. It is a dynamic, okay, structure. It's a dynamic structure, okay, or dynamic point. So at the time of birth, we have seen that it lies at the external os. So whatever we saw was a nulliparous woman, right? So we saw that the transformation zone was at the external os. Now this transformation zone can move in or out. Okay, so it can move in or it can move out. So when does it move in? Okay, it moves in with age. Okay, with age. And important factors here, this is what is important, right? What are the factors or conditions under which a transition zone will move out? So it is seen in like OCPUs, okay, at puberty, okay, and in pregnancy. Okay, so once again, puberty, OCPUs, and pregnancy. Under these conditions, the transformation zone will move out. Okay, now, so what is happening? This is basically metaplasia, right? So, conversion of one mature epithelium into another form of mature epithelium under a particular stimulus. Here it is basically because of the hormones. So that is termed as metaplasia. Okay, and we know that metaplasia is not malignant. Okay, rather it is not pre-malignant. If there is persistent metaplasia, if there is basically the stimulus is persistent, and then it will become dysplasia, then it becomes pre-malignant. Okay, so this phenomenon here is nothing but metaplasia. Okay, it's called squamous metaplasia. Is this physiological or pathological? This is physiological because see, it happens in every woman. Okay, it is seen in all the females, so it is not abnormal. So when does this become pathological then? Let's see, most of the cervix, okay, people who are sexually active at one point or the other, they will get an infection. Okay, they'll get cervical infection. Okay, so when there is infection, how does the epithelium react? So there will be a dysplasia. There will be dysplasia. What is dysplasia? Disorganized growth of cells, the epithelium, right? So there will be dysplasia. Now let's say the infection does not subside or there is persistent infection, excessive irritation, then the dysplasia will persist and then that becomes pathological. Okay, is this clear? So when it is physiological and when will it transform into pathological state? Okay. So now let us get into the some most commons that you should know. Okay, so what is the most common site for CA cervix now? Very clear. But which zone? Where is all the drama happening? It is a transformation zone. So TZ. So this is the most common site for carcinoma cervix. And which is the most common variety of carcinoma cervix? Okay, we know it is squamous cell carcinoma because outside it is lined by squamous cell. So that means there is another type of carcinoma here, right? So endocervix is lined by columnar epithelium. So that will give rise to adenocarcinoma, but the most common type is squamous cell. Okay, because ectocervix is commonly here. Now, if they ask most common site for adenocarcinoma, now the answer would become endocervix. Okay, that is clear. Fine. Okay, so now let us get into the screening part. Okay, so we have understood just the basics. Okay. Okay, then quickly I'll just mention about the risk factors. Then we'll go into the screening part because then it will make sense. So what are the risk factors? Now we have read about infection. Okay, we said infection will cause dysplasia, persistent infection. Okay, which infection is strongly associated with CS cervix? It is human papillomavirus. Right? It is human papillomavirus. Now before that, so see, exposure to HPV happens when there is sexual intercourse. So what are the risk factors? Okay, that is early age of intercourse. Okay, hence early age at first pregnancy or rather first child. Then multiparity, more exposure, correct? And multiple sexual partners. Okay, and STDs, very important. All the STDs, because see, when there is STD, when there is infection, there could be erosion, there could be epithelial denudation and stuff like that. So that means now there is easier path for the HPV or the other viruses to get in. So all STDs are a risk factor. Okay, and it is observed that low socioeconomic status. Okay, so low socioeconomic status is also a risk factor. Okay, and then here something to be highlighted: smoking. Okay, smoking is a risk factor for carcinoma cervix, that to the squamous cell variety. Okay, for adenocarcinoma, see, adenocarcinoma involves the glands. Okay, so then OCP use is a risk factor for adenocarcinoma. Let's write it here. Smoking is a risk factor for squamous cell carcinoma. Similarly, OCP use is a risk factor for adenocarcinoma. Okay, adenocarcinoma. Okay, and um, these are the risk factors. Do you see the concept of, you know, early menarche, late menopause? Okay, basically, estrogen excess conditions here in the risk factors? No, because see, CS cervix is not dependent on estrogen. Okay, on the other hand, when you compare it with the ovarian tumors and endometrial tumors, the risk factor there, the major risk factor would be early menarche and late menopause and use of OCPs there. Okay, because it is estrogen excess condition, like even fibroids, endometriosis. So there you can write them as the, can include them as the risk factors, but here it's not there. Okay, that is to be um, highlighted here. Okay, so once we have done the risk factors, now let us just go into and like understand the how does this develop basically. What are the different stages? Now I said dysplasia, correct? That is basically disorganized cell growth. Now if we take this as the cervical, the epithelium, okay. Now if the dysplasia is limited to the okay, basically less than one third, okay, less than one third here, okay, if that is involved, the let's just mark here. Okay, so this is less than one third, this is around two thirds, this is more than two thirds, correct? So if less than one third of the epithelium is involved, that is CIN1. Okay, more than one third, less than two thirds is CIN2. More than two thirds is CIN3. If the whole of the epithelium is involved, whole of it is involved, but your what is this, basement membrane is intact, so there is no breaching here, then that is called as carcinoma in situ. Okay, it is not, it's known as carcinoma in situ. Now let us say at some point here there is going to be breach. So what happens here? These cells will go out. Okay, the cell will go out here and there will be spread. So basically that is known as invasive carcinoma. Invasive carcinoma. Okay, so that is how we are going to basically grade it, right? So we have CIN1, CIN2, CIN3, carcinoma in situ, and then we have invasive carcinoma. Now there is a recent change. Okay, we don't refer to as 1, 2, 3. What we do is simply call CIN1 as LCIL, 2 and 3 is called HCIL. So what does LCIL stand for? This is low squamous intraepithelial lesion. Okay, let's just write it here. L for low, S is squamous intraepithelial lesion. Okay, as you see, it is within the epithelium. It's not breach, it's not spreading, nothing. Okay, HCL is high squamous intraepithelial lesion. Okay, and carcinoma in situ is called as it is. Invasive carcinoma is called as it is. Now, what is the age group? When do these things occur? This is kind of important, right? So this CIN, right? So this intraepithelial lesions, they're common between the age group of 20 to 30 years. Okay, important, 20 to 30 years. And invasive, sorry, in situ, so 30. So this will be from around 30 to 35 years. This is pretty common. And invasive will become common after 35 years. This is actually having bimodal distribution, correct? And it also gains peak around between the age group of 50 to 60 years. Okay, so this is very important. Okay, we will be coming back to these points again and again. Okay, CIN1, 2, 3. Basically, the intraepithelial lesion will be common between the incidence rather is common. Okay, between the age group of 20 to 30 years. In situ is 30 to 35 years, and invasive will be about 35 years. It has a bimodal peak. It is also increased between the age group of 50 to 60 years. Okay, now one thing to be told here is, now you see there is intraepithelial lesion. Let's say it started at the age of 20. Okay, and then when will she develop invasive carcinoma? At the age of 35. So there is around 10 to 15 years gap here. Okay, so you get 10 to 15 years. If you do screening here, okay, and you find out, okay, some dysplastic cells or something like that, if you can pick up this lady, okay, and treat her in early stages, that is going to be life changing. Okay, so that is why screening is really effective in carcinoma and preventing carcinoma cervix, or rather picking up, okay, and picking up the early cases and treating them. Okay, now let us talk about screening here. Screening is really important. Okay, so this is universal screening. Okay, it must be done in all women. Okay, after the age of 21. Okay, after the age of 21 years, it should be done in all women. Okay, whether they're sexually active or not. Okay, then how do we do the screening? The most important thing we're going to do here is do a Pap smear. Okay, so Pap smear is like, it's basically exfoliative cytology. Okay, I think this was told in pathology. So what we really do is we're going to just pick up the shed cells. Okay, the cells that are shed from the cervix. We're going to pick them up. Okay, and we're going to study them. That's it. Very simple. Okay, so now let me just draw it here. So like the procedure. Okay, we will see how this Pap smear is done. Oops. Okay. That's the ectocervix, this is the endocervix, this is the external off. Okay. Now first is we'll have 3 slides here. We're going to take 3 slides. Okay. The first slide is going to have the smear from the transformation zone, because this is the most common site. So the first thing we want to do is take the sample from there. How do we do this? Okay, we have something called as an IR spatula. Okay, it's a wooden spatula. It's like this. Okay, so now what you do is you're going to hold this spatula. Okay, or you know what I can do, I can just take this here. Okay, look at this. So what is that spatula? The concave part of the spatula goes and sits here. Okay, it goes, okay, just no, it goes and sits like that. So when you're going to rotate it 360 degrees. Okay, you're going to rotate it 360 degrees like that. So you're going to get the smear onto your IR spatula, and then you're going to put it on the slide, and you're going to fix the slide. Okay, so that you will send it to the histopathology. Okay, how you're going to fix the slide? You're going to use a solution which is 95% ethyl alcohol, 95% ethyl alcohol, and the rest of it is ether. So this is a normal fixative that was used. I'll tell you what is used nowadays, recent modifications. Okay, so first one, you're going to take a sample from the transformation zone. The second one is basically the endocervix, right? So endocervix, your spatula cannot go there, endocervix. Okay, there is a deeper part there. So we are going to use the cytobrush. There's something called as a cytobrush. How does that look? So it's going to have a lone stalk. This basically, it's like, it has a number of bristles like this. It's basically like a brush. Okay? And this looks like really mutated and all. Basically, it looks like a brush. You could just Google up the images. So what happens with brush is it goes here. It goes into your os. So when you put it, so you get samples from the endocervix. Again, so you put on the slide, put the same thing and fix. Next, what is the third slide? Okay, you're going to use a control here. Control is taken from the posterior vaginal wall. Basically, the posterior fornix of the posterior vaginal wall. So we're going to use the other end of the IR spatula, and we are going to take it from the very important posterior vaginal wall. Okay, so now we get 3 slides and we have fixed them, correct? Now we're going to send it to the lab, your path lab, and they are going to examine this and give a report. Correct? Okay. Before we analyze the report, I just forgot to mention here that nowadays, okay, the best method, okay, what we are doing is called the liquid cytology. Okay, so previously I mentioned that we're going to use the spatula, we're going to take the cells, put it on the slide, make the smear, put the fixative, okay, avoid air drying, and then we're going to send it. So this is cumbersome, and And moreover, probably there might be some errors while doing this. So what we do nowadays is liquid cytology. Okay, so we're going to have a brush. Okay, liquid cytology. There's going to be a brush, cervical brush. So that we are going to take the sample from the cervix and put it in a bottle. So it's liquid, right? So you're going to get a bottle like this. Okay, so which is having your fixative. What is that fixative? Methanol. Okay, methanol or ethanol, but the major component most commonly used is methanol. So that brush is be there now. So you just all you got to do is put that brush here. Okay, it has got all its bristles. This is not the cyto brush, this is cervical brush. Okay, this is different. Okay, it's a little bigger. And then what you're going to do is you're going to cut it off. Okay, so you're going to cut it off here. Okay, so that this portion will remain inside with the cells put in a fixative, and the rest of the job is done by the pathologist. Okay, fine. So Pap Smear. Okay, it was first done by Georges Papanicolaou, so hence the name Pap Smear. Okay, cool. Now this is the screening method that we normally use, correct? Now what happens in rural areas? What can you do? Can you keep doing this smear and slide and transport issues? Transport to the hospital, then getting the report. So these are all the issues. So now what happens there is we have simpler techniques called VIA and VINI. What is VIA? Visual inspection by acetic acid, visual inspection by Lugol's iodine. So we're going to use 5% acetic acid, 4 to 5% of Lugol's iodine. Okay, so this is acetic acid. This is Lugol's iodine. Right? Now what happens is when you coat the cervix with acetic acid, what happens is the normal areas will appear pink. The abnormal areas, meaning the areas where there is dysplasia, okay, the abnormal areas or where there is dysplasia, what happens? They have increased NC ratio, okay, and nuclear to cytoplasmic ratio is really high. When you put this acetic acid, there will be coagulation of proteins and so on. So what happens is that dysplastic area will now become white. So the abnormal area here is going to appear white. Now if you put Lugol's iodine, see iodine, what it does is when there is glycogen, so in the presence of glycogen, it is going to appear brown. Okay. Okay, so now your normal areas will have collagen. Now imagine dysplastic or neoplastic cells. Do they have glycogen or not? They'll have very less amount of glycogen because all of it is used up, is being used up by the cancer cells, correct? So here there won't be any color change. So here the areas will appear pale or they'll be yellow instead of becoming brown. So what is the point, okay, that you have to remember? Here the abnormal areas will show up as white areas. Here the abnormal areas will not take up any color, rather they will become pale. Okay, this is the point to be highlighted. Now we'll have to see the report. Okay, so now we have sent for Pap Smear. Okay, we are going to get the report. Fine. I think it's a pretty long video already. We'll take up the interpretation of the Pap Smear report, okay, the staging and the management in the subsequent lectures. Okay, so let's break it here and do the report part in the next video. Okay, thank you.